we have here with us Dr. Tejas, and who is a pediatrician resident. And as per we all know, we are discussing here a topic that is the neonatal resuscitation. And this is the second speaker for our Medical 2022. And thank you so much, sir, for coming.
First of all, I would like to thank Rohan for giving me a privilege to speak about this topic. Let's come into the neonatal topics per se. Let's start with the prerequisites or the equipments which we need for neonatal resuscitation. First thing, we need a cord clamp, that's umbilical cord clamp, injection vitamin K, insulin syringes, RT tube numbers, Riles tube 6 or 5 depending on the gestation, suction catheter 8 or 10, 2 cc or 5 cc syringes, laryngoscope blades, preterm and term. Coming to blade, size 00 and 0, ambu with reservoir along with the mask, ET oxygen tubing, ET tube 2, 2.5, 3 and 3.5, 3 green sheets or 3 sterile towels at the resuscitation site, which should be pre-warm, at least 20 minutes in the warm-up, and injection adrenaline, 1 in 10,000 dilution, which is preloaded along with sterile gloves. Okay, coming to whenever you go for a resuscitation, the maternal history, what to ask for the maternal history, there are a list of conditions what you need to ask to the obstetrician. For example, first, what is the gestation? What is the amniotic fluid clear, liquor clear, LSCS or normal vaginal delivery? If LSCS, why LSCS? Indication for LSCS should be important. We should also go through USG reports, whether antenatal scan reports, any anomaly scan, is there any anomaly, or Doppler studies. Mother's blood group is very important, especially in RH negative. Any comorbidities of the mother like preeclampsia, eclampsia, anemia, thrombocytopenia, health syndrome in mothers, which will have subsequent effects on the fetus. And is mother on any medication? The most important part. Next, coming to the neonatal resuscitation per se at the delivery room. Example, let us create a scenario. You go to the resuscitation room, and you start resuscitating a baby. Yes, they are giving spinal. Baby is delivered to you. First, what you will do? Coming to the according to the latest NRP guidelines, that is the 8th edition American Academy of Pediatrics. What we have is prior we would have done antenatal counseling, term briefing, equipment check, everything that I've finished. Coming to whether if it is a term gestation, baby is crying, yes, no. According to the latest guidelines, suction is not recommended. Do not suction the baby if the baby cries. Then, if the baby cries, color is good, heart rate is good, etc., etc., go according to the routine care plan. Cord clamp, then followed by cutting the cord, injection vitamin K.
But in general practice, we do everything. But in general practice,
injection vitamin K should be given in the anterolateral aspect of the thigh. That is 0.5 mg in preterm neonates and 1 mg in term neonates. Along with that, warming, obviously in a pre-ordained warmer, that should be heated at least 20 minutes prior to the delivery. Then passing attitude, giving of stomach wash, then checking for the anal patency, most important part, anal patency, look for any congenital anomalies. Example, cleft palate is the most common anomaly to be missed. Yes, even if the baby has past stools, if it's a female baby, make sure you check the anal patency, because there might be cases of rectovaginal fistulas that might be missed. These are the two most common conditions to be missed. The cleft palate and rectovaginal fistulas. Check the spine, is it in the straight line? Check this, what is that called? Spina bifida or a tuft of hair at the behind. Please check that. Any mongoloid spots, please document that. Any abnormal birthmark, or look for low set ears. For example, what I'm telling is emphasis downs, low set ears, or anything such like that. Please make sure you rule out everything at the delivery room itself. Next, make sure you write down the sex of the baby, very part. For example, coming to the medical ethics part, it is very important. Make sure you write down the sex of the baby very appropriately and counsel attenders. Done. This is the routine care of what we give to the newborn. If it cries, everything, baby is well and good. For example, baby comes out, doesn't cry. What to do next? Obviously, you will warm the baby and you will stimulate the baby. That is something called tactile stimulation, drying and tactile stimulation. After giving tactile stimulation, make sure the baby is crying. No, check for the heart rate. Heart rate is good. Heart rate is good. Continue tactile stimulation so that the baby will cry. So, and suction if needed at this part. Baby is not crying. Suction if needed at this part. The coming to suction, you should suction mouth followed by the nose. Okay, there will be some amount of secretions put up so that baby can't cry. So suction first if needed. If not, no. Then check for the heart rate. If heart rate is well and good, then it's fine, baby will cry by itself. If not, then comes the most important part. What if the baby doesn't cry? Check for the heart rate. Approximately, you can say if it is less than 100. If it is less than 100, go for positive pressure ventilation, what we call bag and mask ventilation at the delivery room itself. Go for the bag and mask ventilation. At least for 10 to 15 seconds, you can try for bag and mask. Check for the heart rate again. If heart rate improves, yes, well and good, baby will cry. If the heart rate doesn't improve, continue bag and mask and go for the endotracheal intubation based on the accordingly appropriate sizing. Yes, this is the American Academy of Pediatric Guidelines or the neonatal algorithm that I'll share with Rohan. People can see that on the group. Yeah. Next, what can be the target saturation of the baby after birth? It varies according to first minutes, 1, 2, 3 minutes, 4, 5, and 10 minutes. In preductal limb, that is right upper limb. In the first minute, if it is 65 to 70, well and good. Second, 75 to 80, 70 to 75 saturation is well and good. At the third minute, if it is 75 to 80, it is more than enough. At the fourth minute, if it is 80 to 85, good. At the fifth minute, if it is around 85, it is better. At the 10th minute, it will reach up to 90 to 95. So whenever the baby is delivered to you, the saturation is 70. No need to panic, because at first minute, normally it will be 65 to 70 itself. Because there is something called fetal transition that takes place from the fetal circulation to the neonatal circulation. That is why you get these kind of saturations. Fine. Next, coming to clamping of the cord. Many people have a doubt regarding clamping of the cord, whether should it be clamped early or late. See, according to the recent guidelines, cord should be clamped delayed. There should be delayed cord clamping, because at least 30 to 60 seconds there should be delayed cord clamping. This is recommended because it will maintain a smooth maintenance of the carotid along with cerebral blood flow. That is the reason behind it. What is it? It also has some potential risks. Coming to the main risk include polycythemia, transient tachypnea of newborn, that is neonatal hyperbilirubinemia, and opening of PDA due to delayed closure. One thing, if there is early clamping, the risk associated are intraventricular hemorrhage, respiratory distress syndrome, late onset sepsis, and anemia. These are the quite common conditions. And many people will have thinking, why do neonates need resuscitation? This I'm telling at the end, because after telling all kinds of this, you will have a basic idea how to resuscitate a baby. Coming to maternal risk factors which will require resuscitation. Okay, maternal history of preeclampsia. Yes, baby will have some amount of uteroplacental insufficiency. Yes, if Doppler studies are abnormal, suggesting of reverse diastolic flow, obviously there will be uteroplacental insufficiency that might lead to NEC later in the later stages of life in the newborn period. So those babies require resuscitation. Next, maternal history of eclampsia. Such mothers will have received magnesium sulfate, and this magnesium sulfate is shown to have respiratory depression on the neonates. Yes, so there is requirement of resuscitation. Yes. And coming to other factors like maternal risk factors, age more than 35 or age less than 18, and any congenital anomalies, fetal bradycardia, nesting non-reactive, infant of diabetic mother, GDM mothers, and mother having severe anemia. So these babies require resuscitation. But according to India, in a tertiary care, all neonates, whether it be normal or high risk newborn, require resuscitation at the earliest. That's something called golden hour. I mean, from birth to 1 minute, then during that minute, make sure you do the neonatal resuscitation. So these are according to the latest studies, I think I've covered most of the parts. So if you have any questions, you can please go ahead.
So we have some questions. Like suppose it's the question one. In a case of a severe congenital anomaly, when does the pediatrician think that it is better to not to resuscitate that baby? And what is any criteria for that? For example, there is an anencephaly in that baby in that case.
Yeah, I got it. So, for example, congenital anomaly per se can be anything. It can be CDH, it can be cleft lip cleft palate, like, right? Imagine a baby will deliver with a cleft lip cleft palate. Obviously, you can't say no to resuscitate that baby. You have to resuscitate, because anomalies would have been done at the third trimester itself. Third trimester, you can't terminate pregnancy at that time.
Yeah, that's true.
Okay, it is left. So we have to resuscitate. Coming to not anomalies, which babies you shouldn't resuscitate, there are some criteria, not criteria per se, some conditions. Any infant less than 23 weeks, or any fetus weighing less than 400 grams, or trisomies 13 and 18, and anencephaly babies. These, I think, better not to resuscitate.
Yeah, that's
Because they wouldn't have a good outcome. Better not to resuscitate. Other than that, I think even any congenital anomaly, congenital diaphragmatic hernia, cleft lip, cleft palate, or congenital VSD, even all these are congenital anomalies. Yeah, spina bifida, we do resuscitate all such cases. Yeah.
yes. So the next question we have. And suppose there is a patient that is a newborn or an infant who has choking, and that too is not in the hospital, outside the hospital. So how will you resuscitate
Okay.
that patient outside the hospital?
Okay. Choking per se newborn doesn't happen. Your question might be if it is there is pulled up of secretion, yeah, that has caused aspiration to the newborn. Yeah, right. How to resuscitate? Yeah, routine suctioning is needed obviously in such cases. Due to over pulling up of secretions, baby would have aspirated. And if needed, you can intubate the baby there itself, because obviously after aspiration, depending on the severity of aspiration, you can intubate and you can transport the baby to the nearest tertiary care center.
That can be done. Who is the next? As you told, we have to suction both mouth and nose, and we have to suction the nose first. Suctioning of the nose first. So what is the reason behind it?
No, you should suction the mouth, then the nose.
Yeah, the mouth.
Yeah, mouth first, then the nose. The reason behind it is because there will be copious amount of secretions in the oropharyngeal airway.
Yeah.
Oropharyngeal airway. So to prevent aspiration of those secretions, we need to suction the mouth first, then the nose.
Okay, so next we have, what is the possible consequence of ventilation with a high pressure or high rate, if you get to that?
Okay. Coming to per se ventilation, it's a broad topic. Based on the ABGs, we tend to set the ventilator rates. Okay, I'll answer these questions to the point. If high pressure is given to neonate, there might be chances of pneumothorax, because the alveoli at the pneumonia is very fragile. Okay, so there might be the definitive amount that we should give to a neonate. At high pressures, it might cause pneumothorax. Yeah, and at high rate, if you give a high respiratory rate to the baby on ventilator, obviously it will cause hyperventilation and CO2 washout. If CO2 washout is there, it will cause free radical injury. And if the baby has periventricular leukomalacia, it will further worsen. So optimum rate at optimum pressures is better to be provided to the baby.
Okay. So as we know, we do Abgar scoring, that to a 1 minute and 5 minute, we do Abgar scoring. Yeah. So should we resuscitate after Abgar or before Abgar only?
Abgar per se doesn't have any role in resuscitation, because Abgar starts after 1 minute, and resuscitation starts both till 1 minute. So Abgar per se doesn't have any role in resuscitation. Only thing Abgar tells is neurological outcome of or motor development of the newborn. That's it. Apart from that, Abgar has no role in resuscitation. Yeah.
Okay. Okay. The last question we have: what is the prognosis of RDS, that is respiratory distress syndrome, and how to deal with it? It's a different topic, but yeah, someone has given actually.
Yeah. For this, I think RDS first of all per se happens only in preterm babies. RDS happens because of surfactant deficiency. Yeah, that'll obviously lung compliance will be decreased. Alveoli can't open up on its own. Yeah, this is per se common way of explaining the RDS. There are grades of RDS based on X-rays: grade 1, grade 2, grade 3, grade 4. Yeah, if it is severe grading, yeah, we need to go for surfactant called Insure technique. Intubate, surfactant, extubation, later put on CPAP. Obviously, surfactant has its own complications like pulmonary bleed or pneumothorax or any such conditions. Yeah, we have to be very careful. RDS babies, any babies less than 27 weeks, according to the latest guidelines, will receive surfactant. That is for sure. After 28 weeks or so, depending on the X-ray, the grade of RDS, obviously, how I have told, grade 1, grade 2, grade 3, grade 4. Depending on the grades, we'll use surfactant and we'll.
Yeah, sir, we completed this topic. And yeah, again, thank you so much for joining. Have a great day.
Thank you so much for giving me an opportunity to explain a short topic. Yeah, but I think I covered most of the points so that you can get to know everything.